Hello, good evening. Welcome to the EUROGEN webinar programme. My name is Michelle Batty and I'm the manager of the EUROGEN webinar programme. I'm also the manager of the European reference network that we call EUROGEN. EUROGEN is the reference network for rare urogenital diseases and complex conditions. And it's one of 24 European reference networks, which were all created by the European Commission in 2017. The ERNs, as we call them, all deal with patients with rare or complex conditions that need highly specialised healthcare. And the aim for us as a network is to try to deliver faster specialist evaluation, more equitable access to high quality diagnosis, treatment and care for those patients with a rare urorectal genital disease or a complex condition that need highly specialised surgery in our case. We collaborate with a variety of different activities. We use something called the Clinical Patient Management System, which is an IT secure platform that enables the experts in our network of soon to be 57 hospitals to have MDTs on really difficult or complex cases. And we can send advice on a particular case to any healthcare professional who requests it anywhere in the EU or EEA. So please feel free to contact us via the website if you have a tricky case and you would like some advice on it. It's completely free. We also collaborate in education and training activities such as this webinar programme, and we also have an ERN exchange programme where we send trainees and sometimes experts on clinical visits between our different healthcare providers to learn and exchange knowledge. And then we also have launched just this year a EUROGEN registry. So the idea is that over time, our 57 hospitals will contribute to this. So quite quickly, we'll have a large real-time clinical data set on all the patients with rare and complex diseases that are treated across the network. So that's a little bit about what we do. If anybody is interested, please feel free to contact us via the website. And now this evening's webinar is about defining strategies for the successful treatment of vesico-vaginal fistula. And I'm really delighted to introduce today Mariangela Mancini, who is one of the urological surgeons based at the University Hospital of Padua. And she's been really active in our ERN since the very beginning, exchanging knowledge and helping to train the next generation. She's active in our work stream 2, which is functional urogenital conditions requiring highly specialised surgery. And she also does oncological surgery. And we have rare urogenital cancers in our work stream 3. So without further ado, I'm sure you'll enjoy Mariangela's presentation. She's got a beautiful description of the history of this really rare and complex disease. So Mariangela, thank you so much for sharing your experience with us, and I'm sure we'll all learn a lot. Over to you. Thank you.
Okay, thank you very much, Michelle. And so I'm going to start my presentation on this difficult topic, so defining strategies for successful management of vesico-vaginal fistulas. I have no conflict of interest. So I think a good place to start when we talk about difficult things for me is the definition. And so I'm going to read it with you. A vesico-vaginal fistula is an abnormal communication between the bladder and the vagina, causing continuous and uncontrollable urinary leakage per vaginum as a result of a trauma to the female pelvis. I think this is a very good definition of this condition, and I just would like you to focus for a few moments on the words that are in this definition, and let's see them together. Like abnormal is something that deviates from normality in a very disturbing way. It is not necessarily disease, but is a very strong deviation from normality. The bladder here is the wounded organ. The bladder loses its ability to function as a reservoir for urine. And this is a very definitive damage to the bladder. The vagina is really a bystander. It's the organ that receives this urine and is perfectly able to function as a conduit, so as a vaginal conduit. So the urine goes to the vagina and then goes out. What is really difficult in this situation is to put a waterproof collecting system to the patient. And so the patient is continuously wet. There is no way to put a nice waterproof plastic bag as we do in ELL conduits on the abdominal wall. In case of patients with vesicovaginal fistula, we have no waterproof system that we can use other than a bladder catheter, of course. But otherwise, the patient is continuously and without control losing urine through the vagina. Urinary leakage, so is the central point of the clinical problem. It is continuous and is uncontrollable. And female. A vesicovaginal fistula is a quintessential female problem. And it is a female problem, not only because only women have vaginas and not men, which is obvious, but also because there are just not so many occasions to damage the male pelvis as there are to damage the female pelvis, because men do not menstruate, do not get pregnant, do not deliver, and there are just not enough pelvic surgeries in men as there are in women to generate such a high number of damage to the pelvic organs. So it is quintessential female. And it is a trauma, it is a post-traumatic event. So when we think about trauma, we have to think that we are dealing, when we repair a fistula, with traumatized tissue. And this is a central point in making a repair successful, to know that we're dealing with traumatized tissue. So think about trauma now. So when we think of trauma, we think of what? Violence, shock, of something with a high energy imposing its effect on something more fragile, leading to destruction and leading to permanent damage. Okay, and this is so the result of this trauma is this fistula between the bladder and the vagina. But there is also one positive aspect of the trauma that I would like to stress here. And this positive aspect is that a trauma is something that is preventable. So we can really do something to prevent the trauma. And so, for example, I want to make a very specific, concrete example here. This is a recent review, systematic review on the most recent and accurate studies on vesicovaginal fistulas in the last 10 years. You see, and this is, for example, is a proportion of C-sections as etiological events for fistulas in all these studies. And you can see that there is a very clear number of C-sections as a cause of a vesicovaginal fistula. So, for example, a good preventive strategy for vesicovaginal fistula is to reduce the number of unnecessary C-sections. For example, there are countries like Brazil where there is a very high number of C-sections even when they are not necessary. Reducing C-sections is a strategy to reduce traumas to the female pelvis. Another example, hysterectomies. Hysterectomies are a very well-known cause of fistulas. You can see how many hysterectomies are in different study groups, the cause of the fistula. And so reducing unnecessary hysterectomies or use good surgical practice, good surgical techniques during hysterectomy is a very concrete way to reduce the incidence of vesicovaginal fistula and traumas to the female pelvis. So I would like to here, I'm going to build with you this is my last final slide. So we go point by point. And so I would like to write down the first point. A good strategy for successful management of when we deal with fistula is prevention. So good obstetrical and surgical practices and reduce traumas to the female pelvis, keeping in mind that a fistula is a consequence of an induced trauma, is a consequence of something that we could potentially prevent. So this is the very first point. But once we have the fistula, so what do we get? So this connection between the bladder and the vagina affects a woman in a very devastating way, affects her body image, affects her hygiene, affects her smell. Okay, and this is important when you think that this leakage of urine is uncontrollable and continuous, so affects very strongly the smell of a woman, affects her sexual life, affects her social life, physical health, and obviously her mental health. So it's a very important clinical problem. The vesico-vaginal fistula, we are talking about this today because these are the most common type of all the genitourinary fistulas. More than 70% a genitourinary fistula is a vesico-vaginal fistula. In the world, there are at least 3 million women affected by an untreated fistula, so continuously damp from urine leakage. These women are distributed in specific regions, which I will show in a minute, less in Europe. But in Europe, we know that the most common cause of a vesico-vaginal fistula is pelvic surgery and hysterectomy in particular. And the last point, which is not, it's a very important point, is that repair of a vesico-vaginal fistula is challenging, it's highly specialized surgery and requires meticulous technique. So it's not an easy problem, an easy thing to deal with. So the etiology is completely different in different parts of the world. Here I'm using this sort of obsolete definition, but it is really difficult to find a good definition anyway. Developed countries, we mean countries with a higher socioeconomic, a higher economical situation and status. We can use different definitions anyway. By developed, I mean Europe, United States, more industrialized country. Developing countries are all the others, and we can see that in all these others countries, labor, obstructive labor is causing fistulas in more than 80% of cases, and in the other cases are due to cultural practices, mutilations of females. Female genitals, and also sexual traumas. Okay, so a totally different story is in the other countries where, as I said, pelvic surgery is the most important etiological event, and followed by radiotherapy. And also, in a good number of cases, 10% of cases, still we have a good, as I showed you before, a good number of obstetrical traumas, including cesarean sections. Here, this is a bar graph that we made, pulling together data from different papers, different studies, and you can see that the world is really divided in so places where the obstetrical trauma is the most frequent etiological event, and places where the surgical trauma is the most frequent event. And places like, for example, you see UK, France, Italy, Japan, in these places, pelvic surgery more frequent, but still we have some cases of obstetric traumas. In India, for example, just to make an example, we go from two extremes: regions where we have only obstetrical traumas, and places like here, regions where we have only surgical traumas, and it all depends on the economical level of the region. So it is very interesting. So here I use the denomination OECD countries, more industrialized countries. So a fistula is a surgical iatrogenic event. In all the other countries, a fistula is a consequence of aberrant delivery, obstructive labor, and female sexual traumas. Okay, so there is a very clear division between different countries in the world. So of the 3 million women in the world affected with by an untreated fistula at the moment, and these are the WHO data of a few years ago, the last data we have, we know that more than 80% of cases are in sub-Saharan Africa and Southeast Asia, okay, where this condition is in 90% of cases still untreated, okay, and or no result. In other countries, a fistula is a rare disease. It's not a common event. We don't have very many numbers published, but we know that it's a few cases per year in most countries. So there is really no country where we have a very high experience in dealing with post-surgical vesicovaginal fistulas. But there is a number of cases scattered around in Europe. So the second point in our final slide, a review of etiology and epidemiology data when we want to assess the problem and to define successful strategies to solve a fistula. And so know that in industrialized country, it's a post-surgical problem, most of the cases, and in other countries is an obstetrical problem. So I'm going to spend a few minutes on my hospital here, because it is not a case that in this hospital there is some expertise on fistula, vesicovaginal fistula treatment. So this is what we call the old hospital. It is one building in the Hospital of Padua, which was finalized, built in its last design in the 18th century. And it looks today just exactly as it looked before. And in fact, I took these pictures. This picture was taken by me 2 days ago, and it is unchanged, this hospital. Okay, but the hospital here, this is the last facade, but the hospital was here centuries before, and a large number of researchers and anatomists have worked here on the female pelvis, on female pelvic organs, and on vesicovaginal fistulas, really. We did a nice and accurate historical review of anatomical research on female pelvis and vesicovaginal fistulas in Padua, which we presented at the EAU meeting in 2015 as a poster. And so we went through a number of documents and texts in Latin, which we translated, and original figures, very beautiful figures, and stories. For example, we found this story dated in 1493 by Benedetti, who was an anatomist who describes the case of a young Venetian lady who had swallowed a hairpin while sleeping. Okay, and that's what he thought, at least. And after 10 months, this hairpin had been expelled through the girl's vagina with excruciating pain. He describes this story as a case report in a book of the time. And he concludes that this hairpin had moved from the stomach to the mesenteric veins to the bladder and then to the vagina of this girl. And this is the story that he recounts, which of course was not true, but this was his interpretation. And I'm going to show you in a few moments what was the real story. So the very first description of something coming out from a girl's vagina, we found it in 1493. So exactly 1 year after the discovery of America. But we also found a number of beautiful, you can see drawings of female pelvic organs, dissections, body dissection on young women done here. And people came from all over Europe to do anatomical research in Padua because cadaveric dissection was possible here, was legalized. And like, for example, Andreas Vesalius, who came down from Brussels, he wrote this beautiful De Humani Corporis Fabrica textbook of anatomy, and he did very detailed descriptions of female pelvic organs. This one, Renier de Graaf, who came from the Netherlands, also years later did very nice, beautiful drawings of, you can see the female pelvis. Here you see the bladder open here, the uterus, the ovaries, everything is, this is the vulva, everything is described with accuracy and beautifully represented. Here again, we see again the graph, we see the bladder open, the urethra. You see there are a very small number of descriptions of the urethra that you can find. And here you can see it, the vagina behind here open. This is an anatomical preparation which he did, and he described very accurately the relationship between bladder, urethra, and vagina. This is another, Caldani is an Italian researcher in 1772. He made beautiful drawings of, you see the bladder here in front, which has been sort of turned on the other side. This is the vagina behind it, and they were showing the tissue interposed between bladder and vagina. Here you can see the uterus, the ovaries, beautiful drawings. And in 1738, we found another description of a young woman. This time it was recorded by Morgagni, who was another pathologist working here. In 1738, this 14-year-old young girl was admitted to the hospital, and this is the internal courtyard of this hospital. It looks today exactly as it looked before, and probably her room was one of these rooms facing the courtyard. She was admitted with sepsis, vaginal bleeding, and excruciating pelvic pain. This girl died a few days later. But Morgagni was able to talk to her before she died, and he did an autopsy the day after. He found urine, perforation of the bladder, and urine in the peritoneal cavity. And what he found, and what he describes, this case report, and he knew exactly what had happened. So he found the hairpin, you see, just like this one, inserted in the urethra, and this was established as the cause of a vesico-vaginal fistula with bladder perforation, vaginal perforation, pelvic infection, and peritonitis. And the girl had told him before that she had inserted the pin in the urethra using the pin as a sex toy. This is what had happened, and she had lost control of this pin, and the pin had fallen into the bladder, probably during orgasm. And this girl was not able to take out the pin, and she didn't say anything to her parents because she was ashamed. So she didn't say anything to anybody, and she was admitted to the hospital, and just before dying, she told the doctors that the reason of this infection was this pin. So this is the very first scientific description of the etiopathogenesis of a vesico-vaginal fistula. Morgagni was also the first one to describe the difference between a vesico-vaginal fistula and a urethro-vaginal fistula. It seems something obvious, but it was not at the time. And he also makes a very detailed and accurate description of a female orgasm, which you cannot find anywhere before him. and of the dynamic of this event, how it had happened. This was in 1738. We also presented this this very interesting work at the EAU meeting a few years ago. And so it is thanks to all this research and all these drawings and all these stories that we have today, with these beautiful descriptions that we have now. This, for example, is a modern textbook of anatomy, basically not so different from the old one I showed you before. You see in this case, for example, this is a description of the peritoneum, which is the black line here, how it descends on the pelvis. This is the Douglas, and this is the uterus, and then the dome of the bladder, and then back up on the anterior abdominal wall. And this is, for example, the extraperitoneal space down below. This is the vagina, the urethra, the bladder. You see here this black tissue is the tissue, the connective tissue interposed between the bladder and the vagina and the urethra, which is the destruction of this tissue is linked to the formation of a vesico-vaginal fistula. So very important to know these stories, and so I put this as a third point in my list: study of history and surgical anatomy of the female pelvis before you want to start talking about healing a vesico-vaginal fistula. So from this experience, I go to the next section of my talk, and here I'm going to present you our personal experience. And when I say personal, I mean the experience of my clinic, the clinic where I work, on vesico-vaginal fistulas in the last 50 years. I want to say here that we selected only vesico-vaginal fistulas and not all the genitourinary fistulas, but we focus on vaginal fistulas either alone or in association with other sort of fistulas. And we were able to go back 50 years on hospital records. So this is a retrospective study, but we did a very detailed search, and we also have a very nice long follow-up of these cases, and this was published in last year. And this is the group is 138 females with a vesico-vaginal fistula treated in this hospital in the last from 69 to 2019. As you can see here, hysterectomy is the reason of the fistula in more than 70% of cases. We also have some obstetrical cases, as you can see. And as a technique of chosen technique in this school, we use the transabdominal repair, either open or, in the last cases, robotic. There were also 10% of cases treated with the vaginal approach, which are a minority of cases, but the technique chosen by the group was the transabdominal approach. And this is the largest series reported so far in the industrialized world of abdominal treatment of vesico-vaginal fistulas. In fact, you can see here, these are, you see the countries with, these are the groups in the group of industrialized country. This is the largest group of abdominal treatment, but you can find more cases of abdominal treatment, of course, in other countries. And I think I'm going to show you the important facts of this study group is that about 30% of cases had undergone previous attempts, unsuccessful attempts elsewhere. So, and then they came to our attention. And also another very important point is that 18 patients required additional intraperitoneal procedures like bladder reconstruction or ureteroenteric reimplantation or intestinal resection or others. So the surgery was much more complex than expected or planned. In particular, 4 patients required subretrigonal cystectomy and neobladder. And all these cases were patients previously submitted to radiation therapy for cervical cancer. Also, 6 patients were treated with external urinary diversion. So these cases were not considered as a vesicovaginal fistula repair cases. They were dry at the end, but they got an external diversion. So we excluded these cases from outcome measurements. And this, we think that this thing should be done in all the studies on fistulas repair. So you should consider only the cases where reconstructive surgery was possible and exclude external diversion from the outcome measurements, which is not always the case because this is not always done. So it is very difficult to compare results of repair of fistulas in different reports. Okay. This is an image, a drawing done by Fabrizio Dal Moro, which is one of the co-author of the paper and also the chief of the clinic here. And it shows, unfortunately, the image doesn't stay. Anyway, I can show you here. It shows the anterior cystotomy. You can see here the bladder has been open and retracted laterally. These are ureteral stents in the ureters. You can use them to help identify the ureters, or also you can keep these ureteral stents after the surgery to keep the bladder dry, even though we did not do this always, but in a number of cases. And here you can see the fistula opening right in front of us. So we chose a transvesical approach for repair. And you can see here the 3 layers: the vagina down below, the detrusor muscle, and the bladder mucosa. So here I get this picture again. So the anterior cystotomy, you see, of the anterior vaginal bladder wall, retraction of the bladder wall, and identification of the fistula, a transvesical approach. Okay, this is the fistula. So what we describe as a technique is a circular incision around the fistula opening in the bladder. Okay, identification of the 3 layers: vagina, detrusor, and mucosa. Excision of the fistulous tract and all the necrotic tissue. Suturing in a cross-shaped fashion. So first the vagina, for example, horizontal, as you can see here, and then the detrusor, vertical suturing, and then again horizontal, the mucosa on top of it. So again, I repeat: minimal dissection of the bladder, anterior cystotomy, and transvesical approach. This is the technique used in our clinic in the last 50 years in the majority of cases, okay, when this repair was possible. And when I say minimal dissection of the bladder, I mean that we try to preserve innervation and vascularization of the bladder to preserve the ability of the bladder to void. Okay, this is very important in limiting additional trauma to the female pelvis. So I put again here the surgical key points in the technique that we present. We did present these points in more detail in a chapter on the textbook Female Urology, which I published together with Professor Artibani before. Anyway, the points are minimal dissection, and in particular, I repeat, minimal lateral dissection on the bladder, transvesical approach, circular incision around the fistula opening, complete excision of the fibrous scar and of the necrotic tissue, separation of the bladder and vagina in order to obtain sliding layers before closure, tension-free sutures, layered cross-shaped closure of the layers, careful hemostasis. Okay, this is as a basic technique. Then bladder reconstruction and additional procedures when necessary, like ureteral reimplantation, for example. Bladder reconstruction was to spend one word when the bladder capacity is not there, when the bladder is not large enough. It is necessary to reconstruct the bladder with different techniques. What we used was the Padua neo-bladder technique. So with the nilial segment, reconstruct the bladder in order to give her more capacity. So we put more points on my final slide. So meticulous surgical technique, minimal lateral dissection of the bladder, reconstructive additional procedures when needed. And also I would like to add here a very important key point in management, operative management of fistula, uninterrupted postoperative bladder drainage, because we want to keep that bladder dry. So the catheter has to work, and we can put ureteral stents, additional external ureteral stents like mono-J stents, ureteral tutorial drains, keep them out of the body in order to keep the bladder dry. We did this ureteral stents in about 40% of cases. In some cases, we just use the bladder catheter, but we need good staff, good nurses to keep those catheters always functioning. So I think what we observed in our experience is that uninterrupted postoperative bladder drainage is one very essential key point in management of fistulas. So I go back to our results. As I said before, we did in 90% of cases, we chose the abdominal approach, which was extraperitoneal transvesical in a majority of cases, transperitoneal when necessary for additional procedures. We did in the last 2 cases robotic assisted transperitoneal repair using basically the same surgical technique and the same maintaining the same key points of open surgery with very good results. Another point that I wanted to show is, you see 6 cases we did external urinary diversions, which then we did exclude these cases from outcome measurement. Okay, 6 cases, and they were all cases treated for advanced cervical cancer in 2 cases with radiation. Okay, of the remaining 118 patients, we divided them in 2 groups: patients previously operated elsewhere and who then came to our attention and were operated again in our place, in our institution, and patients treated in our institution as first attempt. Okay, and we realized that this thing makes a very important difference in outcome. As I said, the follow-up is very long, median follow-up of 28 years, and I'm going to show you more data on this in a minute. Okay, so with a minimum follow-up of 30 months, we have long-term follow-up in more than 70% of patients, and we have very good final results with 95% of patients dry, and 2 patients with persistence of the fistula who refused further treatment, and 2 patients with urinary arch incontinence. at the first attempt, so the patient who were treated in our institution, at the first time we did, the first surgery we did on these patients, gets a success rate of 94%. Okay, and very importantly, we found no association between success rate and etiology of the fistula or any other clinical parameter. So it really didn't make any difference. Size of fistula, age of the patient, menopausal status, or other things. Timing between fistula and repair didn't make any difference. We found statistical significance at the urine variate analysis between fistula size and length. We found a very nice linear correlation. The size is the size of the fistula opening at cystoscopy, and the length of the fistulous tract as measured by the pathologist. We did find a correlation, so it seems to imply that the larger the fistula, the longer and more complex could be the repair. There was really a nice correlation here. We also found a correlation between the site, the location of the fistula in the bladder, and the possibility to do the extraperitoneal approach. For example, the extraperitoneal approach through the anterior cystotomy was possible in all cases of trigonal and supratrigonal fistula, and there was a correlation there. So those are the easiest cases to approach. And we also found a very nice correlation between success rate and number of attempts. Okay, so we went between two extremes. Women previously treated in other institutions, 70% success rate in our institution on the first attempt. Women who were treated by us at the first attempt, so naive patients, untreated patients, 100% success rate. So this was the strongest correlation we could find. So patients who were sent to our attention from other places without trying there to repair the fistula. Those were the cases that we were able to correct successfully in any case, so in 100% of cases. Successful closure. So, and we define this as the absence of leakage as histography on the 14th postoperative day, 100% in patients treated by us at the first attempt, so naive patients, and 77% in patients previously operated elsewhere. Overall, if we look at the entire group, we obtained successful closure in 94% of patients who were operated at the first attempt in our institution. And when we did a second attempt or a third attempt, there is a sharp decline in success rate. So what is really crucial in vesico-vaginal repair is the first time you treat it, okay? The best possible situation is to treat a naive patient for the first time. But also in a center of experience, you can treat a patient treated somewhere else before, but you can get the best success the first time you treat it. And the possibilities to repair the fistula decline sharply at the second and at the third attempt, even in centers of experience. So I would put my 8th point here. Maximize chances of closure at first attempt, okay? So there is no second chance to make a good first attempt when you talk about fistula repair. Try to get the best result at the first attempt. So refer the patient to a center of experience, and in centers of experience, use the technique or the repair that is going to get you the best result. Okay, and here in this case, with these complex surgeries, in these rare situations, rare diseases, we have to think that surgeon preference, surgeon familiarity is something that has to be taken into account. I want to compare this data with the worldwide experience, okay? And here I want just to show you this diagram, just to show you the quality of the papers published on vesico-vaginal fistula repair is not very high when we want to compare different experiences. Like in this recent review so this is a review of the papers published in the last 10 years, okay? So they found 8,288 papers. And so after screening, they only selected 31 papers that were good enough to make comparisons between different groups. So 31 good papers in the last 10 years published. When we look at the worldwide experience, there is one point that is very clear, and is that there are no randomized clinical trials on vesico-vaginal fistula surgical treatment. So there is nothing definitive we can say on this. We know that the world is divided between abdominal approach or vaginal approach, okay? And the results are comparable. Okay, so it very much depends on experience of the surgeons, which is a critical point, and also on training of the surgeons. We see that gynecologists do more frequently vaginal repairs and urologists prefer abdominal repairs. But the best approach is not vaginal and is not abdominal, is not open, is not robotic, is not laparoscopic. The best approach is the one that can provide closure at the first attempt, even in the most complex cases, which are the cases where bladder reconstruction is necessary or other additional procedures. In the case of fistulas, there are no rigidities. There is no one-size-fits-all approach that we can describe, and the flexible mindset is key. So treat different cases in different ways, and consider that success is possible when large experience is possible, and when meticulous surgical techniques are respected. Okay. For example, I show you some data from this recent review. The abdominal approach is chosen in more or less 50% of the cases, in some groups more often, like here it is our group, in other groups less often. Same thing, similar thing for vaginal, the vaginal approach. And success rate pretty similar between the groups that have a higher experience of on treatment of fistulas. So successful surgery possible when you can find good expertise, good surgical practice, good review of data, and good centers with experience in terms of surgeons, but also in terms of staff, of nurses, and in terms of hospitals. So final slide. So this last point, centralized care in centers of experience, because those are the centers that can get the best results. And this, I want to say that this concept was very clear in a study by Cromwell and Hilton in 2012, a multicentric study in the UK, where they show that hospitals that do more than a certain number of cases per year are the hospitals that have the best results in terms of fistula treatment. So centralized care in centers of experience. very clear point. But is this our last point? Is not. We can do even better than this. What can we do? We can share experience, we can share care, and share chances of cure. How? For example, with networks like eUROGEN, which is, for example, the network of urogenital diseases that we all know. And what happens when we do this is that we connect centers in an international network where people can talk, can meet, can exchange experiences, can publish together, can share cases, and this is even better than centralized care in centers of experience. This is putting together different centers in a network that works for them, and that works especially for the patients. And so this, you see, this is my last slide, which is also my take-home message for you, with all the points that we have been talking about in this talk. And I leave you with this, and I invite you to think about it, and to think of how challenging it is to deal with this very abnormal and very disruptive female condition that is the vesico-vaginal fistula. How complex is the fistula, how complex is the surgical repair, how difficult it is to centralize the patients, and how important is to bring all the experts together in order to share their expertise, which is obviously a limited expertise, given that this is a rare disease in our world. And with this, I finish my talk. I thank you for your attention, and I'm ready to answer your questions. Thank you.
So yeah, we've got, so if anyone wants to ask any questions, please send them through now. We've got one coming through already from Frank Martins. I'm hopefully going to interpret correctly. There's a follow-up. So Frank's asking about the success rate of other institutions versus, I think, the referred cases for a second attempt in your centre, Mariangela, saying patients, I think it was 77% versus 100, I think. Is that right? So he's saying patients in good hands in your centre, or if not cured in one attempt elsewhere, is this a reflection of the complexity of the referred cases and therefore a lower cure rate?
Yeah, that's good. But they were not necessarily more complex, these cases. I mean, we didn't find the complexity associated with the success rate, but there were cases that had been treated and had failed, so in which the fistula was recurrent, and so then they came, and so we had to re-intervene on a failed treatment. So, for example, there were cases treated, for example, transvaginally without being able to close the fistula. So this was not necessarily a more complex case, was just a regular case, but just the fact that it was treated and failed was a reason for unsuccess. And also in the same place where we are, so the cases that failed in our hands and then were retreated by us the second time, we observed a drop in success, a consistent drop. So I would say that you get the best chance to repair a fistula independently from the complexity if you do the surgery on a naive patient and for the first time in a center with good experience. Those are the best chances. You can still close the fistula when it's been operated in another place, of course, but the chances to close it at the first attempt are are less. So to answer your question, we did not find an association with complexity of the fistula and the success rate in our hands. And we only find the association between first attempt here, second attempt. So what I want to say is that we shouldn't say that simple fistulas can be treated everywhere and you should refer only the complex cases, because then it's always a little bit difficult to define complex, what it means exactly. I think if you see a fistula in a center where there is not a large experience, you should just refer it, and I think you give the best chance to the patient without dividing cases in complex or more complex.
Okay, thank you, Mariangela. No other questions have come through yet, so I'll give people a couple of minutes to type in anything else they want. Just go to your questions field on the right hand side if you have a question. Just say, yeah, well, the video, the recording of this webinar will be available tomorrow, hopefully later on in the day, maybe tomorrow. We need to do some repair on Michelle's intro, which we shall do, so we can put it onto our YouTube channel. We'll sort that out tomorrow morning. In the meantime, if you're interested in any other webinars coming up, please visit our website. There's a whole list of all the webinars for 2022 on there. Some of them do kind of move around because of circumstances, but it's a good indication of what we're doing when. You can also sign up to our newsletter on the website as well, which will also keep you informed of all upcoming webinars. Yes, I think that's. Oh, the other thing to say, I keep forgetting to say this. For everybody who's attended here, when the webinar finishes today, you'll receive a survey to complete. There's only a few questions. It shouldn't take you too long, but we'd be really appreciative if you could complete it, to spend a couple of minutes on it, because it helps us kind of, we do analyse the results and try and think where we can improve things going forward. So thank you for that. Okay, yeah, so no other questions coming in so far. So give people one more chance before we close. We're already after 7 o'clock, so quite a long, it was a very thorough presentation, Mariangela. So it was quite a long one. So you probably answered questions already. So so yeah, if no one's got anything else.
Okay, great. Thank you, everybody.
Yeah. Okay. Well, thank you, Mariangela, as well, for taking the time to do it. And we got there in the end with everything, despite all the technical problems, just about. So yeah, thank you very much to everyone for attending. We will see, we'll mail you about upcoming webinars as well through a mail shot as well. So thank you, everyone. Hope everyone has a good evening, and we'll catch you all again at some point in the near future. Thank you very much.
Okay. Bye-bye.
Bye.